Thousand Oaks, down in the South Bay, the West Side, all over. We are so excited today to have Dr. Karimis, who's one of our oncologists who's based in Pasadena. We're really happy about that. I will throw in the chat at some point just our website. So if you have any things you want to follow through on looking at some of our other information that we have, we've also have some webinars and community health programs on a lot of cancer-related topics from previous speakers. So you might be interested in that, or just to follow up with some of the other programs we have coming up. So I just wanted to mention that before we get started in this very informative presentation. Thanks so much.
Thank you, Ishara. And now I'm just going to do a brief intro for our presenter today, and then I will hand it over to you, Dr. Karimis. But Dr. Evangelina Karimis is a hematologist and medical oncologist who practices in Pasadena. While she has an emphasis on breast and gynecologic cancers, she treats patients with all types of cancer and hematologic conditions and enrolls patients in UCLA Health's full scope of clinical trials. She is board certified in hematology and medical oncology. When it comes to patient care, Dr. Karimis prides herself on treating everyone as an individual and considering each person's work and family situation when making treatment recommendations. Dr. Karimis received medical degrees from the University of Southern California Keck School of Medicine. She then completed internal medicine residency and her hematology oncology fellowship at UCLA. Dr. Karimis was born and raised in Pasadena and is happy to serve her home community. So thank you so much for joining us tonight, Dr. Karimis. I will hand it over to you.
Yes, thank you, Rachel and Ishara. Thanks for arranging this. You know, breast cancer is
it's body hair. It's a part of the body, but it is still.
Right, here's something in the background.
A statement, and also it's interesting how body hair is a fashion statement. It really
you hear that? Okay, there. Okay. So breast cancer is a topic that is near and dear to my heart. One, because I'm a woman, and two, just because there have been so many advances over the last decade. And I think sometimes the layman community doesn't realize how things have changed. And so this talk really kind of focuses on where we've been, even way back when, where we are now, and kind of where we're kind of headed in terms of survivorship and whatnot. Let me see. So kind of the objectives of this talk are to focus on where did cancer treatment start, where are we now, and then really kind of focusing on a mishmash of commonly asked questions and topics that I get in the office all the time from patients, and then focusing on survivorship. So a lot of this stuff people probably know, but I like to always emphasize it. So it's breast cancer remains the most common cancer in women. 1 of 8 women will be diagnosed with breast cancer in her lifetime. And while people are constantly asking me, what is the risk? Is it a genetic thing? Is it environment? Is it diet? Really, your #1 risk factor is just being a woman. So even though men can get breast cancer, they do have breast tissue, it's just not as common. And so just being female is enough of a risk factor for breast cancer. And historically, we've always looked at breast cancer as just all one disease. But as you see, as we get smarter, we're really recognizing that it's more than just one disease. So a common myth is that cancer is a modern disease. It actually is not. We've been able to identify cancer cells even in the bones from dinosaurs. And when we look back at Egyptian papyri, they commonly will talk about bulging tumors that they would see people develop and not be able to be cured from. Obviously, at that time, they didn't have a lot of technology and whatnot. And so their kind of main mode of trying to treat it would be to cut things off or burn things off, which were minimally effective. Hippocrates and Galen were the first ones to kind of start to think that maybe this wasn't a local disease, maybe this was more a systemic illness, thinking about the bad humors and whatnot that they kind of thought about back at that time. And then you'll have to, I apologize for the Greek emphasis, it's part of my background, so obviously I have a bias. But Hippocrates was really the first one to recognize that not all growths were necessarily malignant or deadly. There were such things as benign growths, and he was the first one to really start to study and look at these different cancers and look for differences in terms of location, body sites, all of that. And so as we know, many words come from the Greek, and so cancer is actually no different in that regard. So when Hippocrates looked at these tumors and he looked at the blood vessels that supplied them, the blood vessels to him looked like the claws of the crab. And so karkinos in Greek is crab, which led to our medical term of carcinoma. And as we know, crab in Latin is cancer, and that led to our more colloquial term for the disease. So flash forwarding, many years, the 18th and 20th to the 20th centuries were kind of the time of major advances in both surgery and anesthesia. And so at that time, we kind of returned to this idea that breast cancer was a local disease, leading to like extensive mastectomies and other surgical excisions. But what was again recognized was that it didn't really matter how much they cut out. So they started off with a little bit, women would still recur. They cut out more, women would recur. And it didn't matter how extensive the surgery was, a subset of women would still have relapse of the cancer. And what they did notice was that if they removed some of the endocrine organs, either the ovaries or the adrenal glands or the pituitary glands, that those women would oftentimes do better, suggesting that there was some systemic component again of cancer. So by the 1950s, cancer was again being recognized that maybe it's more than just a local problem. Maybe there's more systemic disease that we do have to consider. And between the 1940s and 1970s, it really ushered in a new era of where we developed most of our modern day chemotherapies. And so it all started off very fortuitously. So during World War I and II, a common agent used in warfare was mustard gas. And the soldiers would end up dying pretty horrifically from bad infections as well as bleeding, just due to the myeloid suppression or bone marrow suppression from the agent. And so somebody in their infinite wisdom thought, well, who could possibly benefit from, scaling that down a little bit? Who could benefit from that effect? And so it was used in people who had blood cancers, who needed some type of bone marrow suppression. And it was the first time that a medication could be used to actually induce cancer remissions. So based off of that early success, it led to the development over the next several decades of people really focusing on developing more chemotherapy drugs. And then it was just kind of silence for many decades. After all of this kind of progress for many years, there really was nothing. It would just be different kind of recipes of different chemotherapy agents, dosing them different ways with really not, meaningful differences in terms of responses of people. And so where are we now? How is breast cancer treatment better now? So I'm going to focus on a lot of this stuff in separate sections, but just briefly, obviously we've got screening now. The surgical world has changed a lot. We have the benefits of radiation treatment. We have methods for breast cancer prevention. And then we have the world of improvements in systemic therapy, which include targeted chemotherapy and hormonal therapy. So we'll start by focusing on early stage breast cancer. And so when we start in terms of screening, so routine screening mammograms started around the 1980s. Currently, it's now become the leading reason women are diagnosed with breast cancer. The screening recommendations for any individual should really be a discussion between that individual and their physician. And I'm kind of giving you now some general guidelines, but it's certainly always a topic open for debate, even in the medical community. So for standard risk recommendations, so meaning most women in the population that are going to carry less than a 15% lifetime risk of breast cancer. If you're less than 40 years old, it's not generally recommended that you should start screening mammograms. For women who are ages 40 to 49, there's various recommendations depending on the governing agency. So there's lots of different agencies out there that kind of put out their recommendations. But between 40 and 49, it's considered shared decision-making, and it's generally recommended every 1 to 2 years. I will tell you my own medical oncology bias, and most people in the oncology community, we're gonna say that starting annual screening at 40 years old. Between the At ages of 50 to 74, it's generally recommended screening every 1 to 2 years again. Again, my medical oncology bias is continued annual screening at that time. And then a common question I get, because a lot of times on a lot of the recommendations, it will say over 75 years old, no further screening required. And I think that this is can be a little bit of a difficult question to answer. To me, anytime you do any medical test, whether it's screening or for treatment purposes, you really have to ask your question, are you going to do anything with that information? And is it going to have a meaningful impact on that person's quality of life or survival? And so I think it's always important to start reassessing that once you get to 75. But honestly, if you're 55 and you only have a 2-year survival because you've got horrific MS, then maybe it doesn't make a lot of sense for you to be screening at that age as well. So again, when you're over 75, if you're still, living actively, you would still act on an abnormal mammogram, meaning you would consider the treatment modalities that we're about to talk about, then you may want to consider continuing your screening past that age as well. So in terms of mammograms, there's multiple studies that have shown that it has helped decrease mortality related to breast cancer, but it's not a perfect test. And we all acknowledge that. It misses about 15 to 20% of cancers. So if you do feel that there's a mass just based off of a mammogram, that's not necessarily enough. It doesn't mean to say don't proceed with further workup, but just know that it's the best test that we have at this time for screening. There's different versions out there. There's been for years the standard digital screening, and nowadays we also have 3D mammograms. 3D mammograms are basically the best way that was described to me. It's like taking multiple 2D mammograms, and then the technology allows them to kind of reconstruct a 3D image. And so it does allow the breast radiologist to have a better view in terms of what they're seeing. It does seem to increase cancer detection. It's still not clear if maybe there's increased recall rates. So meaning that they see more, but is all of that, should every woman be called back for some of the things, it might be picking up a little bit too much that's irrelevant. And then there is a slightly increased radiation dose with 3D mammograms. A lot of times I'm asked about screening ultrasound and MRIs, and unfortunately there's just no data to suggest their benefit in screening. They are useful modalities if you do detect a mass or if you're being worked up for a breast cancer. So they're an adjunct for workup, but as of right now, there's no standard guidelines to recommend ultrasound and MRIs to standard risk women. There are some state policies that if you are a woman that on mammogram has dense breasts, the radiologists are required to recommend an additional modality to you. And so you may see that on your reports. But as I mentioned, the data is a little sparse in terms of a standard risk screening program. MRIs can be considered in high risk populations. And what I mean by that, some examples are, say, a patient who still has breast tissue and is a BRCA positive patient, say a patient who previously had a diagnosis of lymphoma and may have had extensive radiation treatment to the chest wall. That would be another reason to consider. Radiation related to breast cancer does not put you at high risk requiring an MRI. Or there are online estimation tools, so like Gale equations or other type of predictive models out there that you can put in your clinical information and will estimate what your lifetime risk of breast cancer is. And if yours is estimated to be greater than 20%, that may also qualify you for screening MRIs. So when we talk about treatment for early stage breast cancer, if you require all of these different treatment modalities, the usual order is going to be to start with surgery, then proceed with chemo, then radiation, and then what we call endocrine or hormonal therapy. We tend to not overlap treatments. That way we make sure that we know exactly what symptoms are related to whatever treatment you're getting at that time. It is possible that surgery and chemo could be reversed in the right clinical situation. So let's focus on treatment. So when we talk about surgery, as I told you in the past, it was always more surgery is better. And what we've learned with time is that that is not the case. Doing more surgery in most women does not improve outcomes. So many women will qualify for what we call breast-conserving therapy or a lumpectomy. And as you can see in this woman in this picture, it can be just a small, very small incision like this. You can barely notice it in many patients. When we look at outcomes, when we talk about a breast-conserving therapy, it's going to be a lumpectomy along with radiation treatment to the breast. The outcomes are equivalent to a mastectomy. So oftentimes people think lumpectomy is as good as a mastectomy. It's not. It's a lumpectomy plus radiation treatment. The outcomes are equivalent to mastectomy. For many women who are having surgery for breast cancer, they will also undergo something called a sentinel lymph node biopsy or an axillary lymph node dissection if there's already a high suspicion for lymph node involvement. A sentinel lymph node biopsy is a surgeon using tools to try to identify the very first lymph nodes in the armpit area that would potentially drain the cancer cells if they were trying to escape. It gives us prognostic information for the cancer. It helps guide us in terms of how aggressive we should potentially be for later therapies that we're going to talk about. And especially if you do have a lot of lymph node involvement, you may require an axillary lymph node dissection to properly debulk the tumor and give you better prognosis in terms of your surgical outcome. So the decision between whether to do breast-conserving therapy or mastectomy is really a balance between making sure you get the optimal cancer treatment and cosmesis. So as you can imagine this woman had a much bigger tumor and needed a much bigger incision and had a much smaller breast. It's not going to make a lot of sense to take a huge chunk out of a small breast. The cosmesis is not going to be all that great. So that person might be a better candidate for a mastectomy. Sometimes it's also just based off of patient's wishes and just based off of, the fear of having to go through all of this again. The other nice thing that has come with time is we are getting better reconstructive options. So it's great to say, oh, have a mastectomy, but that can be a life-changing thing for most of us. And so over time, most of us are familiar with implants. Nowadays, there's also more and more flap reconstructions that are being done. And what that is that the surgeon will go and actually make an incision either in the lower abdominal area, sometimes it can be in the back area, where the plastic surgeon will remove a piece of the muscle as well as some of the soft tissue and use that tissue to reconstruct the contour of the breast. And so this becomes a more viable option for a lot of women who maybe don't get the look that they're wanting with implants or have issues with tissue related to radiation treatment or other complications from surgery. And as time is going on, there's more going on in terms of using fat stem cell and grafting and all of these other modalities. And then when we talk about systemic therapy, a lot of times people can get really confused because they think, well, I had a great surgeon, they removed everything. Why do I need to consider any therapies after surgery? So as I mentioned to you before, we know historically that it doesn't matter how good your surgery is, there's going to be a certain subset of women where the cancers are going to come back. And that is probably based off of cancer cells that we just can't detect on scans or in blood tests. And so the role of the therapy or the systemic treatment is really to help reduce the risk that those cells that may have already escaped into bones or lungs or liver will not come back in years to come and cause us further problems. Modalities that we use are chemotherapy, endocrine or hormonal therapy, as well as targeted therapy. And we make these decisions in terms of what would be the appropriate therapy based off of the pathology. So for every patient that comes to see me, I get the surgical specimen or the biopsy specimen, and I look at certain features and I'm trying to make a risk assessment in terms of what the benefit of the additional therapy would be compared to the risk of the therapy itself. So we look at things like tumor size, lymph node involvement. We look at how ugly the cells look underneath the microscope, which is something called the grade. And then most importantly, we look at the subtype of breast cancer. And so certain things are checked like the estrogen receptor, the progesterone receptor, and the HER2 receptor. And so what we know clinically is that there's 3 different subtypes of breast cancer: hormone positive, which means that it's estrogen or progesterone receptor positive, HER2 positive, and triple negative. So what do I mean by this? So the pathologist will take the cancer cells and does stains for each of these 3 types of receptors. And depending on what they see, they will give a report that tells us how positive you are for that particular receptor. So if you see this picture here, this is the cancer cell right here. This is the inside of the cancer cell. This is the outside, like the blood area. Right here is what we call the estrogen receptor. Oops, sorry. And right here, this estrogen binds to that estrogen receptor, and then that leads to a cascade within the cell that eventually leads to changes in terms of proteins and DNA being replicated and leading and driving that cancer cell to keep growing. Okay, and so we have identified for breast cancer up until this point that estrogen receptor, progesterone receptors, and HER2 receptors can play have a major impact in terms of cancer propagation. Oh, and just so I should mention, so triple negative by definition means it's triple negative for those receptors, which is a way of saying that we don't know yet specifically what the targets are for triple negative, but that is obviously soon to come. So even more interestingly is that if you take cancer cell lines, so you take tumors and you grow cancer cells out of those tumors and you create lines within the lab. And then you take those particular cell lines and you look for gene or protein expression on microarrays. So this is like a scientific technique that they do in the lab. What they can see is what genes get turned on and which genes can get turned off, or what proteins are expressed or not expressed. And when you do this across many different cell lines, you can see that they kind of fall into certain families. That even though these cancer cell lines started at different patients, there are certain patterns that follow along within them. And so this starts to classify people even in the lab into even more subtypes of breast cancer. So luminal A's tend to be the very strongly hormone positive tumors. The basal subtype tends to be triple negative breast cancers, and the HER2 positive, as you can imagine, tends to be HER2 positive. But there's other types that we see in the lab, and with time, hopefully we'll find more targets in terms of what else is driving some of these cancer growths. Another useful tool on the pathology side is gene expression profiling. So this is used specifically for hormone-positive breast cancers. The common terms that you've probably used out there for testing or heard of out there for testing is OncotypeDx or Mammaprint. And what these are, they're genetic assays that can be used in hormone-positive, lymph node negative breast cancers to kind of help determine if there's a role for chemotherapy. So there's a certain subset of patients that have a certain stage of disease, and we've always kind of treated them with chemo because they were high enough risk that you would want to consider it, but you never knew, maybe you were over-treating a lot of these patients. And so these gene expression profiles look at the expression of certain genes within the tumor, and based off of data that the company has collected, helps give information in terms of what the anticipated benefit would be from chemotherapy based off of experience from prior tumors that had similar expression assays. And so with the use of this, we're helping to kind of decrease the amount of chemotherapy that potentially we're giving a lot of patients. So why does all of this matter that I just mentioned to you? So part of the reason is that we've known for years that we're probably over-treating a lot of people. And so unfortunately, out of fear, we kind of throw everything at people and just hope that we get the best results. And with time, we've started to take a look and try to identify who is lower risk, who can we hold off on giving treatment, because there are long-term implications to a lot of these therapies that we're offering. The other part of it is that if we can glean more information in terms of what is driving these tumors and what's driving cancer growth, then we can try to target those pathways and stop using these big chemotherapy bombs that cause a lot more toxicity and also a lot more effects on normal cells and not just on cancer cells. breast cancer has really become one of the prime examples of how we're not just have one kind of stamp of treatment for everybody. We do kind of alter treatment depending on the person's pathology, who they are, and a lot of these additional testing. And so in terms of systemic therapy, when we put it all together, the pathology information, everything, that's what really helps us determine what additional pills or chemo, et cetera, we would offer a patient. So I wanted to focus a little bit on HER2 positive breast cancer because it's really been over the last like 15 years clinically, the big area that has changed the most in terms of breast cancer management. So back in the 1980s to 1990s, it was identified that there was a subset of women with breast tumors who just historically did poorly. It didn't really matter what you did for them. They just relapsed and they would eventually die of their disease. And so the tumors were assessed, and what was found was that they overexpressed that HER2 receptor. And this was seen in about 20 to 25% of breast cancer patients. So back to kind of looking at the cells. So imagine this is a normal cell. You expect some HER2 expression. But in the HER2 positive breast cancers, what you see is that there's just overexpression of that HER2 protein. And similar to that earlier diagram I showed you with the estrogen receptor, what happens is that the HER2 receptor will get activated and then lead to downstream effects within the cell that lead to rapid cell replication and divide and tumor growth. And so when these researchers looked at women who had tumors that were heavy in HER2, overexpressed HER2, versus ones that did not express HER2, you can see that these survival curves show that there was a big difference in terms of prognosis. The women that had HER2 overexpression did much more poorly than the women that did not have HER2 overexpression. And so what happened is they developed a drug that specifically targeted that HER2 protein. It's a drug very well known now, Herceptin or trastuzumab. And what it is basically an antibody that recognizes that HER2 protein and prevents that HER2 protein from being activated and leading to the cell replicating. It also, by various mechanisms, helps assist in terms of identifying the tumor cell for death by the body. That being said, it's also very low toxicity. And when women were treated with this medication in conjunction with chemotherapy, their prognoses basically improved to such a degree that it was similar to women who had lower risk breast cancers. And from that, there has been a plethora of anti-HER2 drugs that have been developed over time. Most of these are dedicated to advanced HER2 positive breast cancer, but just in the last couple of years, there's been 3 new drugs, and they've all kind of revolutionized treating this very high risk group. One of these novel agents that is used occasionally in early stage breast cancer, but more commonly in advanced breast cancer, is called Kadcyla or TDM1. And the reason I wanted to highlight it is that it's an interesting drug in that you can see here, this is that same trastuzumab or Herceptin molecule, and what is attached to it is a little pocket of chemotherapy attached to it. And so what ends up happening is that Herceptin molecule that we already know goes and binds onto the HER2 receptor and essentially delivers the chemotherapy directly to the cancer cell. So instead of using chemotherapy that's just kind of going throughout the body, you're delivering the chemo straight to your target. So why does all of this matter? So believe it or not, as much as people hate chemotherapy and targeted treatment, and you hear about all these improved prognoses over time regarding breast cancer treatment, much of that benefit over the last several decades has been due to improvements in chemotherapy and targeted therapy treatments. And so it's important to realize that that has been a major impact in terms of improved prognoses for cancer treatment. The other smaller factor is also obviously the fact that we've implemented regular screening with mammograms, leading to earlier diagnosis. Another common, I think, area that confuses people is the role of genetic testing. So I think anytime somebody is diagnosed with cancer, the first thought is, did I inherit this? Is something wrong with me that led me to have this cancer? And believe it or not, unfortunately, most cancers are just random events. Only about 10% of breast cancer diagnoses are actually an inherited genetic mutation, with the most common being BRCA mutations. But there's a lot of newer ones that have been identified, including PALB2, ATM, CHEK2. There's a whole slew of them. There are very defined guidelines in terms of who should be tested. Usually nowadays, what I recommend in anybody who's concerned, or particularly anybody who has a striking family history, is to talk with a genetic counselor. But some of the high-risk groups are particularly young age of diagnosis of your cancer, so usually less than 45 to 50 years old. If you're of Ashkenazi Jewish background, if you, in one individual, there have been multiple cancers, if there's a diagnosis of ovarian cancer, particularly under 60 years old, male breast cancer, or multiple generations of people who've been diagnosed with cancer. The American Society of Breast Surgeons recently actually made their recommendation that all women with a diagnosis of breast cancer should have genetic screening. Unfortunately, I don't know how well that flies with insurance companies. Obviously, having a personal history of breast cancer at, say, 60 years old does not scream of, necessarily that there's a genetic reason, but certainly it's not unreasonable to talk with your physician and see if maybe a genetic counselor would be important to see. And the reason why it's important to know about some of these things is whether there should be prophylactic surgeries that are considered. For example, in BRCA patients, we may consider doing bilateral mastectomies, even in somebody who doesn't have a history of cancer, whether you need prophylactic oophorectomies or removal of the ovaries. And sometimes it can change some of the screening protocols for certain cancers as well. Another common question is the role of some of these bone agents. So what we call osteoclast inhibitors. The most common one that's been used is one called Zometa, or zoledronic acid. So the theory behind this many years ago was that breast cancer, one of the common places it likes to metastasize to is the bones. And the thought was that this class of medications can kind of change the microenvironment in the bones. And by changing that microenvironment with the medication, maybe you make it less hospitable for cancer cells to set up camp there and continue to grow. The problem is the trials have been conflicting about the benefit. And even some of the positive trials have really shown a very tiny benefit. So I wouldn't say that using Zometa has become a standard use. You can have some side effects related to it. But some of the considerations for the infusions would be to do it every 6 months for 3 to 5 years after your breast cancer treatment is completed. I will not say it's a regular part of my practice, but I do know some clinicians who do consider this, especially in patients with more advanced disease. But like I said, the data is not very strong for it. So in summary, for early breast cancer, really our goals over the last couple decades have been to identify who needs less treatment, find more targeted therapies with less toxicities, improve early diagnosis, and attempt to prevent cancer when possible in high-risk populations. So let's talk a little bit about advanced breast cancer. And so by definition, advanced breast cancer just basically means disease that's outside the local breast or chest area. So meaning it's moved into the lungs, the bones, the liver, perhaps the brain, something along those lines. It's not considered curable, but it continues to be very treatable. Local therapy for metastatic disease is going to take a backseat. So we're not usually going to use surgery and radiation treatment very commonly with more advanced disease. We're going to focus more on systemic therapies. Some of the drugs that we use may not be approved for early stage disease, but they have been developed and approved and studied in metastatic disease. So for hormone-positive breast cancers, we briefly touched on a little bit in terms of endocrine therapies. I didn't focus too much on it because I think a lot of people know about those therapies, but things like tamoxifen, the aromatase inhibitors. And for people who have metastatic disease, back in 2015, a drug called palbociclib or Ibrance got expedited approval because it completely revolutionized the outcomes in women, first-line treatment for women who were postmenopausal, hormone-positive metastatic disease. So what was found was that the combination of what we call a CDK4/6 inhibitor, such as palbociclib, in combination with that aromatase inhibitor, was significantly better than women who were taking an aromatase inhibitor alone, which was the standard of care at that time. The CDK4/6 inhibitors really carry minimal toxicity. People tolerate them very well. The major issue is low blood counts related to it, but again, patients don't seem to really notice any issues with it. And people can do well on this combination of therapy for years. For HER2-positive breast cancers, as I mentioned before, there's just been a slew of development of new anti-HER2 therapies, and the studies continue. I can tell you at UCLA, we're constantly putting new things into trials. And what's nice is a lot of these therapies are now becoming even better for penetrating what we call the blood-brain barrier. So historically, one of the areas that HER2-positive breast cancer treatments do not treat very well is the brain. And part of it is because Mother Nature made it such that if you got an infection, the last place you would want it for it to easily be able to get into the brain. So there's this very nice protective layer. Unfortunately, a lot of our chemotherapy and other drugs have problems penetrating that layer as well. So some of these newer HER2 therapies actually penetrate very effectively, and that is improving outcomes as well. And then for triple-negative breast cancer that's advanced, there's some role for immunotherapy. I know immunotherapy has gotten a lot of press out, in obviously the medical community, but particularly in the layman community. And there is a small population of people with triple-negative breast cancer that may benefit from that. And what this slide was meant to show is, so this is prior to 2000 and then after 2010 for patients who had advanced HER2-positive breast cancer. So just so you have an idea, right in between here is when Herceptin was developed. And so even in these patients who had advanced HER2-positive breast cancer, you can see how different these survival curves are. That women before 2000, I mean, it was a pretty quick death sentence for them. And now there's women who can do very well for a long time, even with metastatic HER2-positive disease. So let's talk a little bit about survivorship, because I think it's one of these topics that's been addressed for years in the medical community, and it's now in breast cancer really kind of had a resurgence over recent years. A lot of the major governing cancer organizations have even made it almost like a standard requirement for cancer centers to really address this further. It can be a little bit of a difficult thing to monitor, but I think it's important as we realize that more and more people are living a long time with cancer, particularly with breast cancer. So what does survivorship mean? Basically all it means is that you had cancer and you're still alive. So I don't always think cancer survivor is like the best term, because I do think that it's kind of two distinct groups with two different kind of goals in terms of what you have to address for them. So the first goal is the people who had early stage breast cancer, got treatment, are cancer free, and now their concerns are recurrence and side effects from prior treatment. For the second group is basically women who have metastatic cancer and are on long-term therapy, that they have a chronic disease and they have management issues that we have to address in that regard. So in terms of follow-up for the early stage people, generally you're going to follow up with a medical oncologist. Sometimes it could be your primary care physician, but I think nowadays most people with their medical oncologist. Just for follow-up, and we're going to talk about what that entails. The reason being that the highest risk of relapse is going to be within those first few years. And so for that reason, you're following up with your medical oncologist every few months, and then as time passes, those follow-ups do spread out with time. As I mentioned, the majority of relapses are going to occur within the first 5 years. That is more specific for triple negative and HER2 positive breast cancers that tend to be more aggressive. I always tell people nothing is set. I know there's this idea if I make it to 5 years, I'm in the clear. Maybe not a bad assessment for triple negative and HER2 positive, but again, nothing is 100%. But for hormone positive breast cancer patients, unfortunately, that's not the best marker of being completely cancer free. Hormone positive breast cancers can relapse even 10, 15, 20 plus years later. The good news is that if it takes a cancer 20 years to come back, it's probably slower growing and probably going to be a little bit easier to manage. But that being said, it is unfortunately part of the course for that disease process. When we talk about relapse, we think about it in 2 ways. What we call local regional relapse. So meaning, at the breast area, in the lymph node area, this will happen in about 4 to 7% of early stage breast cancer patients. That type of disease still may be very curable with local therapy. So that's why it's important to have breast exams, and even if you've had mastectomies, just to make sure that there's nothing that may be present, as well as follow up with mammograms. In terms of distant disease or metastatic disease, bone metastases are probably one of the most common areas, particularly for hormone positive breast cancers. Organ metastases in the liver, lung, brain are more common in triple negative and HER2 positive breast cancer. The other thing that we want to be looking out for in these early stage patients is another breast cancer. So a completely de novo, has nothing to do with your initial diagnosis, but you got to imagine if you have breast tissue that remains, whatever led to that first breast cancer, you've got the same genetics, same environmental exposures. So you're going to be at a slightly increased risk of development of another breast cancer. And for people who kind of have standard risk of breast cancer, that risk of a second breast cancer is about 0.5 to 1% chance per year. So in terms of follow-up, what I'm looking for when I'm talking with a patient, do they have new symptoms that suggest to me a potential for recurrence? Do I have to address any symptoms that they may be having to their current therapy or their prior therapy? And then on exam, I'm checking the chest wall, I'm checking lymph nodes, making sure I don't see anything that's evident of recurrence. If for patients who are on a drug called tamoxifen, there is a slight increased risk of uterine cancer. And so I'm making sure that they're also following up with their gynecologist in that regard. In terms of imaging, we're just making sure that people are staying on top of their annual mammograms. Were there any recommendations for closer follow-up from the radiologist, ultrasounds, MRIs, anything for follow-up of something that they did see on the mammogram? And then obviously for higher risk women, the role of MRI is also considered. And then I think the thing that it can be a little bit difficult for some people once they're done with all their cancer therapy is that you feel like you're just kind of sitting there waiting to find out in years to come whether the cancer is going to show up somewhere else. And people often at times ask about what we call surveillance scans, so surveillance CTs or PET CTs. Unfortunately, there's no data that doing that surveillance programs like that are going to improve your survival. So what that means, if you wait until you have symptoms, that difference between doing a surveillance scan and you having symptoms that lead us to doing the scans does not improve your survival. And you expose yourself to a lot more radiation by doing regular CT scans. And so there's really no role for doing those scans. It's honestly the same thing for labs. So it's commonplace, and I will say I do it for all my patients, checking blood counts and liver function and tumor markers. But again, there's no data that it actually benefits people or improves their survival. But I feel that it is a fairly low risk type of procedure. And I think it does allow people to feel that at least something is being monitored on top of the exams and mammograms. And so I do it, but again, there's no data to support it. So some of the long-term effects that we see from local therapy. So it's not uncommon to have a lot of local effects after surgery as well as radiation treatment. So, people have cut into you, so it's not uncommon to have benign growths, either seromas, which are fluid collections, or sometimes the fat tissue will just kind of die on itself, something called fat necrosis, and it causes this very discrete mass, which can be very alarming if you don't know that this can happen. The radiation especially can cause a lot of chronic skin and soft tissue changes, so the breast tissue just feels harder and just not quite as soft as the other side. It's not uncommon to have chronic kind of pain or numbness due to the effects on the nerves from the local therapy. Decreased arm mobility can be a problem, as well as lymphedema. So a lot of times, I think it's important to address these things with patients, because some of this stuff is stuff that we can actually address, lymphedema, arm mobility, stuff like that. But even more importantly, I think sometimes just letting women know that some of this stuff is just normal, so you're not freaked out every time you get this like little flinch of pain that sometimes can come to the breast, because obviously your mind goes to the place that this must be another breast cancer. From the prior radiation treatment, there's always a low risk of effects just from the scatter of the radiation on the heart and lungs. But it's pretty low risk nowadays and pretty nominal, but it's always something to address with your radiation oncologist if you're having new symptoms. And then the long-term complications of chemotherapy. So probably the one that is always the most difficult is what we call neuropathy. It's where some of our chemotherapy agents affect the nerves and the tips of the fingers and the toes especially. Unfortunately, just like in the breast, nerves are not resilient. And so there has to be an expectation that there may be a little bit of residual damage after the chemo. Some of it can improve a little bit, but it doesn't oftentimes come back 100%, which can be very difficult for people long term. Some of our agents do have effects on the heart or the lungs. Again, fairly low risk, particularly since we do generally, particularly for the cardiac stuff, monitor those effects. And then in young people, obviously ovarian failure and infertility is a legitimate concern with some of our agents. And so that always has to be discussed, and hopefully discussed ahead of time, particularly if people are still interested in fertility, so we address those things before we start treatment. Many people ask me about the risks of secondary cancer. So you get treated for breast cancer, great, but now I have, leukemia because of it. It's actually a very, very low risk, very low with most of our chemo agents. Some agents a little bit higher than others, but it's pretty rare across the board. There is a slight risk of it with radiation treatment as well, but overall, it's generally a fairly low risk. And then cognitive changes, fatigue, psychologic changes, I kind of group all together into what we've termed chemo brain, for lack of a better term. Unfortunately, chemo brain is just this very non-specific term, and it unfortunately has a lot of symptoms that go along with a lot of the other stuff that come with a cancer diagnosis. So depression, anxiety, and then just being tired out, just having to stress about this. And so a lot of times helping people just kind of stay on course for their treatment, and then trying to help address these issues after the fact. But unfortunately, if there are effects of chemotherapy on the brain, it's not very well investigated. We just don't have great treatments for it. But as we'll talk about in a little bit, there are some things that people can do to kind of at least minimize it as much as possible. And then I didn't talk too much about endocrine therapy, but endocrine therapy are drugs that basically block certain hormonal pathways to the hormone-positive types of breast cancer. And those therapies can have effects on bone health. As I mentioned, with tamoxifen, there's a slight increased risk of endometrial cancer, menopausal symptoms, including hot flashes, mood changes, changes in sexual drive. All of these things can be very important issues to address with patients who are going to be on anti-hormonal therapy for 5-10 years or more, depending on whether they're metastatic or on some type of hormonal therapy. And then musculoskeletal complaints that can happen with some of them as well. And so when we talk about lifestyle and the things that we can affect, obesity is probably one of the prime risk factors, as I'm sure is not surprising, for many common cancers, and it's associated with increased risk of cancer recurrence. Exercise during cancer treatment has been shown to benefit in terms of the results, as well as improvement in quality of life. So back to what I was talking about with chemo brain, you know, I've just seen it even personally, even though, and there's data out there that patients who are more active in the midst of treatment, their recovery afterwards is just much more robust. And they seem to have less issues with the fatigue and the mood changes. Now, it's a little bit chicken or the egg. Is it the people who are generally in better moods and just are tolerating their diagnosis better, more willing to go exercise, and vice versa, right? But I have seen patients who were not particularly motivated to exercise, but you know, encouraging them to do so, they really did rebound after much more smoothly than say their counterparts that did not do it. So it, you know, exercise is never a bad thing. And then when we talk about diet, everybody's always asking me, is there a special cancer diet? Unfortunately, there's just no special cancer diet. Most of the data seems to kind of be inconclusive for anything in particular. And most of the stuff just seems to kind of support what cardiologists would say: lean meats, fresh fruits and vegetables. There is a suggestion that obesity, again, at diagnosis is going to portend a poor prognosis, but there are a lot of confounding variables in those studies, particularly when it comes to how to dose chemotherapy properly in a very obese patient and stuff like that. There is some suggestion in the data that losing weight can improve your outcome, but a lot of the more specific studies are still pending in that regard. What has been shown in multiple studies is that exercise does seem to improve survival. Now, whether that's a breast cancer survival or just an overall health survival is not clear, but it doesn't seem to matter what type of exercise. It does seem to be dose dependent. The more you put in, the more you benefit. Most of the studies did focus on cardiovascular types of exercise. And as I mentioned, it just helps improve a lot of the post-treatment symptoms as well. So in general, the recommendations are going to be to maintain a healthy weight, to BMI of 20 to 25. Try to engage in at least 30 minutes of moderate physical activity at least 5 times per week, a healthy, balanced diet, and then limit alcohol consumption is another thing that is a little bit up for debate, but it does seem that people who limit alcohol consumption do seem to do better from a breast cancer perspective. In terms of metastatic cancer, it's going to be a lot of the same issues that we would recommend for early stage breast cancer. But really the goals of metastatic cancer are to balance the cancer control with the treatment toxicity, right? We're not going to cure people of metastatic cancer. Our goal is for them to have a high quality of life for as long as possible, but we're not looking for longevity if somebody's miserable and in bed all day long. What has become an interesting dynamic now is that patients are living a lot longer with advanced disease. It's become kind of a chronic disease for a lot of people. And you might be surprised, some of people you might work with or even family members that you don't realize are going through long-term therapy for breast cancer because they do so well. It's not as obvious anymore. And what has become interesting, at least from my practice, is as these people live longer, originally when you were talking about somebody who had metastatic cancer and maybe would have a couple of years left, you would kind of forego a lot of the normal healthcare maintenance, right? Like you might not worry about the cholesterol as much. Do they really need a colonoscopy? A lot of these other stuff. Now, as people are living 5, 10, 15 years with, you know, more advanced disease, are these issues stuff that we need to start addressing again? And then, as I mentioned, the same lifestyle recommendations as for early disease are only going to benefit patients with metastatic disease as well. So in summary, basically, beyond better survival in early stage breast cancer, people are also just living longer with advanced breast cancer with a high quality of life. Further studies are really looking into more strategies for more targeted systemic therapies that will hopefully continue to improve survival and minimize toxicity. Thank you so much.
Thank you so much, Dr. Karimis. Would you mind if I ask some questions that have been coming through the chat?
Please.
Okay, and you could also probably stop the screen share if you want.
Okay, perfect.
So people can see you a little better.